good morning and thank you so much for the invitation. I'm really pleased to be here. I'm going to talk a little bit, following on, I think, nicely from Peter's talk, about what's the process of generating evidence that is influential in alcohol policy, and also how can you best communicate about alcohol policy evidence to policymakers and policy stakeholders. I work at the Institute for Social Marketing and Health, and we work on public health policy, policy evaluation and behaviour change. And I forgot to put in a little mention, but I just thought I'd say it now because I'll forget later, that we're running an alcohol policy workshop in January that I know a couple of people in the room are already signed up to. It's in Edinburgh, it's free. And if you're interested in going to it, talk to me about the link. I can send it on. It's run by the Spectrum Consortium and it's over 3 days, and it covers really alcohol policy evidence and research in lots of detail with some leading speakers from around the UK. And I also wanted to mention that we're hosting an international alcohol policy conference in June next year, that KBS conference that goes around the world, but it is obviously much closer to home in Glasgow than it would be in Australia or South Africa, where it's been over the last couple of years. Unfortunately, it's not free, but it is very good value. And it really a massive opportunity for any of you interested in alcohol research to network and build your skills. So just get those two things out of the way. I want to just thank the funders for the studies that I'm going to mention, and all of my collaborators who are too numerous to mention, because I'm going to dip in and out of a lot of studies here and I don't have any conflicts to declare. So why do we need alcohol policy research? So I'm going to start with just a quote from one of the longest serving TDs in the Dáil, who said that politics is much more about emotion than it is about evaluating evidence. Now that's a little bit depressing if you're a researcher. So I'm going to make the case today that alcohol policy evidence, and indeed alcohol policy research, is valuable at all stages of the policy process. So first of all, in understanding what is the problem that you're trying to solve with policy, who is exposed to that and how do they experience it. You want to also then be able to shape the policy decision-making process. So trying to understand what would the likely impact be of policies, how acceptable and feasible might they be, what are the kind of policies that there is the best evidence for. And then once a policy is introduced, you want to reduce uncertainty about the impact and implementation of those policies. And then, of course, you can also use research to understand the decision-making process and the policy-making process, who's lobbying, how were decisions made, what were the influences. And so right across the piece, I think alcohol policy research has a really important part to play, but it's not the only part in terms of policy decision-making. And sometimes we talk, I think, a bit too much about evidence-based policy as if evidence is the only thing that should inform policy. So it has a really important part to play, but so does emotion, and so do values and local knowledge and priorities and obviously resources. But I suppose we would argue that evidence should be in there in the mix in terms of informing those decisions. So how do you get evidence into policy? Well, traditionally, I think the way researchers think about this is, you do your research and then you think about really innovative ways to disseminate those findings and make sure the policymakers have heard about them. And I would argue that that's often too late. And so really when we're designing research studies now, we're talking to policymakers right from the start. Before we even have an idea, they're helping to shape our ideas. They're helping to tell us what they're interested in, what are the potential policy windows or opportunities coming up. When might they make a decision? So the research that you do might be very different if you know that a decision is imminent compared to something that you're like, look, we'd like to do that, but it's not going to happen this Parliament. It might be 2 or 3 years down the line. And then right through the conduct of policy research, we're involving policy stakeholders. So they might help us to choose the samples for qualitative or quantitative research. They're involved in helping us to think through the theory of how a policy might work to help guide data collection. We're adapting to a new government in the UK, so we build in flexibility into our studies so that we can then adapt and pivot to what the interests of the new government might be. And then it gets to the point where you've got findings, but even before you finalise those and publish them in a peer-reviewed journal, you're sharing them as they emerge and inviting policy stakeholders, both in government and charity sector, to help you to understand your findings and to interpret your findings. And as you go then thinking about how you communicate them through policy consultations and briefings as we would be the more traditional way. So just to go back then to think about one of the sort of main areas where research can contribute to policy, I'm particularly conscious obviously the Public Health Alcohol Act, several of the measures are already in place and not all of them have been evaluated, and there are more really world-leading measures coming around labelling. And so I want to focus a little bit about what are the kind of methods and thinking that you need to put in place to do that kind of evaluation so that you can understand whether a policy has worked or not. If it has worked, why, how, for which groups, for when, and what you might need to do to keep shaping those policies. So minimum unit pricing, as an example, we've obviously just increased the minimum unit price in Scotland from 50p to 65 pence. That's because we were able to show through the evaluation who was and wasn't being affected by that, and how the value of the 50 pence minimum unit price was kind of decreasing over time in terms of public health impact. Evaluating real-world policy is hard. The most effective interventions are population-wide interventions like price, availability and marketing controls. And there's lots of reasons why they are particularly difficult to evaluate, but I suppose it fundamentally comes down to it's not a randomised controlled trial where you're picking a very specific outcome that you want to influence through a new intervention. Everyone is exposed to a population-level policy at the same time. You can't randomise half the country to have minimum unit pricing and the other half not to have it. So that means that that population is also exposed to a whole pile of other things that are happening at the same time. And as well as that, as Peter really showed, the date of implementation of a policy can actually be a bit fuzzy. So prices were already rising before minimum unit pricing came in. And then also there might be a little bit of lack of compliance. So in some retailers, it might not be conforming to the policy even on the date of implementation, depending, and that applies to lots of policies. So that all makes it really complicated to decide what the impact of the policy is. It's not as simple as does policy A lead to B. There's all this complexity happening sort of outside the room, if you like, in this picture. So when you're trying to think then about whether a policy has worked, well, first of all, we need to think about what success means. If we look at the Public Health Alcohol Act, there are on .gov.ie, there are very clear objectives set out as to what the policy objectives of the Act were. Some of them are specific. So the first one is very specific. The remainder are not specific, but even though these are actually better than you get for a lot of public policies, there are still lots of different outcomes that you could look at to decide whether initiation had been delayed. What harms would you measure to decide whether the harms have been reduced? Is it all possible harms? Is it specific harms? But still, relative to other policies, they're quite clear. We've been involved in evaluating 2 changes in local policy on opening hours for licensed premises in Glasgow and Aberdeen. And in those 2 cities, they made a local policy decision to extend opening hours late at night for pubs and nightclubs. And there wasn't really any clear written down objectives, particularly for Aberdeen, of those policy changes. And so in our evaluation, we needed to actually look at documentation, look at the minutes of meetings and do stakeholder interviews with people who were around at the time to basically say, well, what were you trying to achieve with these policy changes? You know, what were the later opening hours supposed to provide in terms of benefits? And the goals of the policy were a bit vague. And so when we did get to it, you see things like, you know, well, we wanted to reward the nightclubs that were like good practice nightclubs and allow them to open a bit later, or, you know, economic outcomes, or talking about reducing disorder by staggering people's movement out of licensed premises. But we only found out that these were the intended outcomes of the policy changes through the research that we'd already started. So at the time when we were actually trying to develop the project to evaluate these changes, we were influenced by the international literature, and the international literature suggests that later opening hours lead to higher number of alcohol-related assaults and ambulance call-outs in the night time. And so I suppose what we've come to think in this study is that we were actually a little bit skewed in our thinking, because we were sort of thinking, well, how do we show whether these policy changes have failed or not? And for us, whether they failed or not was, did they increase assaults and did they increase alcohol-related ambulance call-outs? But actually, even if we found no change in those outcomes, a policy should be judged on whether it achieved the things it was meant to achieve. But what we see is that there's a much higher evidence bar for public health interests than there is for the arguments that are made for the policy in the first place. So people, you know, advocating for later hours can make vague statements about, oh, this will help with disorder because people will be staggered in how they live onto the streets. But nobody sort of says, where's your evidence to show that that will be the case? And so the case for a liberalising policy is often very vague. But then we're sort of tying ourselves in knots trying to do super robust evaluation to show the unintended consequences of that policy. And so we've pivoted a little bit from that in this particular study, using both qualitative and quantitative evidence to cover a whole range of outcomes, so that even if, and we don't have the latest findings yet, even if the policy doesn't increase assaults or ambulance call-outs, we're looking at, does it actually deliver any economic benefits? Does it actually improve practice in premises? What does it do in terms of pressure on services that isn't shown in crimes or in ambulance call-outs? And what does it do for staff safety in the nighttime? And so I think once you have an outcome and you've defined an outcome, you still need to think about how you can tell whether that has been affected by the policy. So you need to be sure that the outcome is one that can plausibly be linked back to your policy. So, for example, you could look at total ambulance call-outs, but we know that most of those ambulance call-outs, although a big proportion, most are not related to alcohol. So any change in call-outs because of an alcohol policy might be hidden if you look at total ambulance call-outs. So ideally, you really want to know, has the policy made a difference to alcohol-related ambulance call-outs? And so you want to have something on your patient records that can tell you, is this call-out actually related to alcohol? Now, in Scotland, there is a box that paramedics can tick. So in theory, you can look and you can go, right, let's just look at the alcohol-related ambulance call-outs. So hooray, you've got an outcome that is specific to alcohol. But sadly, because paramedics are busy people, and when they're even busier, like, well, funnily enough, late on a Saturday night when there might be a lot of alcohol-related call-outs, they don't always tick the box. And when we checked this by having a paramedic review 4,000 records to judge using the whole record whether the call-out was alcohol-related or not, and we found that this tick box identified only about a third, less than 40% of actual alcohol-related call-outs. So then there's no point in looking at whether your policy has made a difference to the trend in alcohol-related call-outs using this tick box, because that's just changing all the time. And actually at the times when they might be busiest and alcohol-related call-outs might be going up, they might be even less likely to tick that box. So what do you do? Well, we spoke to the stakeholders in the Scottish Ambulance Service and they told us that paramedics are very good at telling the story of each call-out in the free text notes that they write. And so we developed a pretty cheap algorithm that identifies words and phrases in the free text that are related to alcohol. And we tested that against the 4,000 records. And we were able to show that that was identifying almost all the alcohol-related call-outs that a professional paramedic could identify, with a really high level of accuracy. And that's now embedded into the Scottish Ambulance Service data systems as a new alcohol flag. And we can then use that because it's consistent over time. We can use it to see whether policy makes a difference to alcohol-related ambulance call-outs. So how do you do that? So once you have this robust outcome that you're happy that is related to your intervention and it doesn't change in volume sort of randomly or for recording reasons over time, you can use time series analysis. Now, apologies to those of you who are familiar with this, but just to sort of take it back to basics, it's essentially a statistical technique that involves analysing the number of data points. So what's the level of the outcome, say weekly or daily or monthly, over a period of time. And what you end up with is a graph that plots, like what Peter was showing, outcomes over time. So this could be anything. Let's say it's alcohol consumption, or it could be hospital admissions. And what you're looking at then is where the policy is introduced. You consider that an interruption in the time series. So this is a specific type of time series analysis called an interrupted time series analysis. And what you're trying to analyse is whether there's a change in the trend after the policy was introduced. Now, you could just look at the trend, and if you look at this, it does look like maybe there's a bit of a downturn in this outcome in this sort of fake series that I've put together where the policy is introduced. But you can't just look at that. You have to statistically analyse whether that's a significant trend. It could just be noise, things moving up and down randomly. And you also critically don't know what would have happened without the policy. So I suppose to expand on Peter's point about a control, it could be that the outcome that you're interested in, let's say hospital admissions, is getting worse, but it might have been even worse again without the policy. Or it might be that it's getting better, but it might have been even better again without the policy. So you have a problem where even if you find significant changes in the trend that happens after a policy is introduced, you can't necessarily conclude that the policy has been the thing of all the other things that are happening in the country at the time that have made the difference to that trend. So what do you do? This is where you use a whole range of strategies, one of which is a control. And as Peter illustrated really nicely, after minimum unit pricing was brought in Scotland, alcohol-related deaths rose. But because the evaluation used what's known as a difference in difference method, so it's another form of time series analysis, with England as a control area, we were able to show that they rose by statistically significantly less than they did in England by analysing those two trends in parallel. So that's one way that you can deal with attribution. Another way is that you can have a control time series. So another outcome with the same population, but it is less likely to be affected. So let's say the Gardaí decide that they're going to increase enforcement in the early hours of the morning around drink driving. You could use ambulance call-outs that happen in the middle of the day as a control time series. And so you could compare the trends at night time to daytime to understand and to be able to tell a more robust story about what the likely impact is of that intervention. And then the third way, which is probably the most technical of the three, is to have what's called a synthetic control. So in our evaluation of the later opening hours in the two cities, we wanted to use Edinburgh as a control city, and we are still doing that. But the peer reviewers for the study said that they didn't think Edinburgh was a suitable control for Glasgow and Aberdeen, that it was too different, and that we should use what's called a synthetic control. Essentially, that is taking several cities that didn't change their opening hours over the same period and creating a kind of an amalgam. It's a modelled amalgam that generates a sort of synthetic trend, an imagined trend that's modelled. And then you're comparing the trend in the actual cities where the intervention took place to this modelled trend for multiple cities combined where they didn't have the intervention. And you can use all of these methods in the same study. So what you're looking for is essentially trying to understand, what's the pattern of effects that I'm seeing using these different methods, and do they all point to the same story or do they contradict each other? A key part of being able to tell that, though, is the qualitative evidence. And I'm primarily a qualitative researcher. That's where I started before I sort of got into the mixed methods. So I absolutely believe the qualitative data is really essential when you're doing these policy studies. And the statisticians can do their time series analysis, but they can't tell you why the trends have changed or how the policy has been implemented to be able to understand why those trends might have changed. And an example of this is so important when you don't find an impact of a public health policy, to be able to explain why. So Scotland lowered its drink drive limit in 2014, and in a paper that we published in The Lancet, we found that that didn't have an impact in terms of reducing road traffic accidents. Now, if we'd stopped there, the story would be that it didn't work. But when we did qualitative work, we found that the public did know about the reduction. They were influenced by it in terms of their behaviour, but it was just that there was, at the same time, the police and the authorities thought the job is done, we don't need to worry anymore, and they stopped enforcing as much, and they stopped the publicity campaigns for a few years. And so the road traffic accidents, the two things balanced out, and you didn't see that reduction in road traffic accidents. Similarly, we looked at how public health teams in local government in Great Britain use strategies to try to influence licensing decisions, so premises licensing decisions. And we evaluated whether the areas where those public health teams do lots and lots of work to try to influence licensing decisions had better outcomes in terms of hospital admissions and crimes compared to the areas where they don't engage, or the public health teams are too busy or choose to do other things. And we didn't find that public health team input made a difference to crimes or hospital admissions over quite a long period in a large study. But because, again, we had a lot of qualitative data, we were able to understand from the licensing stakeholders who were making the licensing premises decisions that they really valued the public health input, and that it was making a difference to their thinking, and that it was making a difference to some of the decisions that they were making, but that ultimately the licensing system itself was fundamentally incapable of making big enough changes that would actually impact on crimes and hospital admissions over time. So the power of the system just wasn't there, even if the public health teams were doing a really good job at their end. So just finally, before I move on briefly to just talking about how you communicate about policy evidence, I would say that because it's complicated, one thing that really helps to kind of cut through that is to have a kind of theory of change. So setting out at the start of a policy evaluation, what is it that you think, what are the effects this policy might have? What are the pathways through which it might make a difference for what subgroups and over what period of time? And it might be that some of the impacts might be longer term and you can't actually measure the impact of them, but you can still theorise them and you can still try to understand what those might be. And ultimately, at the end, you can then appraise whether, when you apply the evidence that you gather to the pathways in your theory of change, does the pattern of impacts point to a clear story? And so I suppose the challenge here is using methods that are robust enough and gathering data across using sort of the best of qualitative and quantitative methods so that you really have the ability to be confident and clear in your findings so that you can tell that clear story to policymakers. So I'm going to finish just with a quick pivot to a completely different project that I could have spoken about probably for the whole time today, but I decided not to go into it in too much detail, because if you go to this website here, you can read the full report from this study, the executive summary and a communications toolkit that translates the findings into practice. So with this study, we wanted to understand how framing influences public opinion about alcohol. So the idea being that, I suppose, as researchers, we are choosing what information and concepts to include in public media and political communications, and we're choosing how to combine them. So we're all framing our communications, even if that's not necessarily conscious. And so we wanted to understand how to more effectively frame our conversations with policymakers, and how to help policymakers to present policies to the public in ways that are most likely to get support for population level policies, for the most effective alcohol policy interventions, essentially. And so I can't talk you through all of the methods of the study, but very quickly what we did was do some baseline work to understand what do the public think about alcohol and alcohol policies currently. We compared that to what experts would like them to know and understand, and that gave us our gap that we were trying to fill. We developed lots of different stories or narratives to frame alcohol and alcohol harms. We tested those qualitatively and quantitatively with samples of members of the public, and that allowed us then to look across the piece to conclude what are the best ways to talk about alcohol to actually build support for policy. So we had 15 outcomes, including kind of stigma-related outcomes, understanding of harms, and support for various policies that we tested each of the framing strategies against. That was then translated, so the findings of that were translated into 6 key messages in the communications toolkit. And I suppose one of the key reflections that I would have from this is that what you think works in terms of changing public opinion and generating support for policies is often not what actually works. And sometimes the things that we really feel strongly will make a difference to public opinion are not actually the most effective things in practice. And there's lots of reasons for that, including how sometimes information makes people feel defensive, or it makes people blame other people. So if they see a problem that they're really worried about, they think, well, it can't be me that's creating that problem. It's not me and my drinking, it's someone over there who's drinking more than me. And so I won't go through these in detail. It's all in the toolkit, but I suppose just to pick out a couple of things in the last sort of minute that I have. Talking about the lower level harms from alcohol was at least as important as talking about the more severe harms. So talk about the being sluggish in the mornings, not feeling great at your work, not feeling grumpy taking the kids to football on a Saturday, not sleeping properly, feeling anxious on a Sunday. Those things were just as important to talk about as liver disease and cancer and deaths. And because they're less scary, people can relate to them, and it brings people into the problem. They then can see that we're all part of the issue and not just those other people over there. I would also say that explaining how advertising and marketing works is really important. I think sometimes I see that recommendation and go, we already do this, but actually we don't often help people to understand how they are affected by advertising and marketing. People often think, oh no, well, I buy my booze because that's what I do, and those adverts don't make any difference to me. But actually, by explaining how those strategies of the industry are tying alcohol to all of the things that we love. They're tying alcohol to the football, and they're tying it to the rugby, and they're tying it to weddings and social occasions. And they're not bringing to the fore the things that should be at centre stage in those occasions, but they're kind of usurping our love for those things to try to sell us more booze. And that kind of allows people to sort of see how that advertising and marketing is working. The leave some things unsaid is possibly the bit I would point you to in terms of the most surprising findings from the study. You know, the things that we thought would work, and we all had our kind of favourite things that were like, I think this is definitely the best way to talk about alcohol, that weren't always the most effective. So just to summarise, I suppose the right evidence has a really important place in informing and improving policy, and including understanding what has worked or not worked for what outcomes, but also in what groups and what groups of society, and how that has worked and how it has made a difference. But evaluations need to be designed. We can't just look and eyeball trends in data. We really need to use the statistical methods that are available to us, along with those qualitative methods, to be able to draw really robust conclusions about what the impact of policies is. And then finally, I would say the close working with policy stakeholders in government and charities and health service and across the piece, including at the start of research studies, is often really critical to that translation of evidence into policy. And we now have evidence, that could be repeated in Ireland, but, it's as good as we've got in terms of understanding what framing works to actually improve support for policy is likely to be helpful both to policy progress and also to politicians who might want to sell a policy to the public. I'll leave it there. Thank you.